Hello, everyone, and welcome. I'm Stacy Fox from the Market Intelligence team of Open Minds. Today, as part of our weekly Circle Elite Executive Roundtable series, Ross Robinson, former CEO of Hill Country Mental Health and Developmental Disability Centers, and Open Minds Senior Associate Jason Lippman, will share how to build a clinic without walls through the example of Hill Country, Texas. In addition to serving as CEO of Hill Country Mental Health and Developmental Disability Centers, Ross served in roles that addressed adult and childhood mental health, intellectual and developmental disabilities, substance use disorder, and juvenile corrections prior to joining Open Minds. With over 15 years of executive experience in the health and human service fields, Jason brings his expertise in strategy, public policy, and government relations, managed care, and communications to our Open Minds team. Before we get started, a few housekeeping reminders. While your audio will be muted during today's briefing, we want to hear any questions you may have. Please feel free to submit those in the question box on the right side of your screen, and we will present them at the end. Also, the slides and recording from today's briefing will be available on the Open Minds website tomorrow. Ross, I will turn it over to you.
Well, good afternoon, everyone, and for our friends in the Western United States, good morning, and thank you for joining us today. Several months ago, I was in a conversation with Monica Oss, and we were just talking about this concept that Hill Country developed and implemented, and she wanted me to present that to you today. So I would like to visit with you for a few minutes now about the Clinic Without Walls, and again would welcome any questions that you have at the end. And the one thing that I will promise you is that if I cannot answer your question immediately, I'll work with Jason and the team, and we guarantee that we will do everything possible to get the answer to you. I would like to discuss today's objectives very quickly. The first is to review the concept of what a clinic without walls is, and we'll discuss in more detail. But it's a flexible, mobile, person-centered service for persons with serious mental illness or youngsters with serious emotional disturbance who have difficulty accessing care due to their logistics or socioeconomic barriers. Also, what we want to do is briefly discuss the market drivers for services that are delivered by a Clinic Without Walls. We'll talk about some of the steps involved when we initiated this practice and this concept. And then we'll end it by discussing some of the challenges that we faced when we implemented, the things that we did to address those challenges, and some of the lessons we learned. Essentially, just to begin with, when we developed this concept, we actually were inspired by history, and specifically the history of frontier America. When we looked at this concept, if y'all recall, and how we see in most movies, forts on the frontier were originally constructed in the U.S. With walls around them. This first picture is Fort Boone in Kentucky, and then this next one is actually a photograph of how the Alamo looked prior to the battle. And you can see that there is a large wall surrounding the complex. But in the 1800s, the U.S. cavalry changed the paradigm in the Western United States. This is a photograph of Fort Davis in far west Texas, just outside of the Big Bend area. And if you notice, there are no walls around it. The reason being is that traditional frontier American and Spanish forts were built for defense. People lived and worked close to them. Troops stayed with them for protection. And anyone who needed assistance or security, safety, had to come to the fort. The U.S. cavalry changed that concept. They realized that hostile forces were not likely to approach or attack a walled protected facility. What that meant was that soldiers who were not protected by walls would have to utilize the fort as a base for mobile operations and interact with anyone they found where they found them. The fort was still there as a base. People could come to it for safety and security. People could come there for trade. People could come there to rest on their journey. So there was still a base of operations, but largely the movements of the troops were meant to be mobile. We decided to use this same concept on the Clinic Without Walls model. And it's important to note that what I'm going to talk about are evidence-based practices. So the services themselves are not fundamentally unique. It's how we provided those services. If you look on your left-hand side of this slide, the service is a system of care. It emphasizes mobility, partnering with community health practitioners, creative technology, person-centered care and services. To do this, we established bases in 2 rural communities. These 2 communities were 18 miles apart from one another, and they were 20 miles from the nearest mental health clinic that we operated. It provided a full array of evidence-based services, but our goal was mobility, accessibility, inclusion. We offered transportation. We embedded with community healthcare providers and mobile outreach providers. And we also offered expanded hours. We had telepsych services, but it's not just telepsych services that people would come to the base and interact with a psychiatrist or a psychiatric nurse practitioner. Instead, for some folks who are either unable or due to their emotional or mental status unwilling to come to services, our staff, and particularly our certified peer specialists, would take laptops to them, and they could then interact with the licensed provider via laptop. We offered licensed therapists, licensed chemical dependency counselors, nursing, a driver to bring them to and from services and to other community services. And all of our staff were trained in person-centered thinking principles. But the idea also was we would travel into the community to meet with persons at locations of their choice. For example, they may want to meet at their local church or a coffee shop or a library, which might not be as stigmatizing as coming to quote unquote a clinic where in a rural community, everybody knows who you are and everybody would know why you're there. One of our requirements eventually became that every staff member would work at least 1 full day completely in the community, meeting with people either in homes or in the location of their choices. And we'll talk more about a grant that a church that serves as one of our quote unquote bases received to provide additional community outreach with local businesses. Now, in talking about market trends and how this dovetails with market trends, in the research that I did on where the market is headed for behavioral health services, the good news is that it is expected to expand. The opportunities and the funding capabilities nationally and internationally in behavioral health are expected to expand. And one of the predominant driving forces about this, as we all know, is COVID. So the stresses caused by COVID, the growing prevalences of behavioral health disorders are now becoming a major driving factor for the market. But if you notice on the bottom right, the upsurge in mental health activities in the healthcare sector is to provide novel services. And as we see in this next slide, if you look at that bottom bullet, one of the problems that we all face is how to get treatment to people and or how to get people to treatment. So the research that I did is that enterprises that offer flexible, mobile, creative systems that bring services to people and address their social determinants of health in an entire system of care are going to be extremely attractive to funders. in the United States, the federal government, with the expansion of Medicaid and Medicaid opportunities, is still expected to be the most significant major player in terms of funding. But additionally, what the research is showing is that the managed care organizations, insurers, are more and more addressing the behavioral health issues and looking for creative ways to address them. So this brings us to the question of, okay, how do you create a clinic without walls? You know, how do you actually go about accomplishing this? One of the first things that you have to do in this to be successful is you have to understand the environment. You need to understand, and it's consistent with person-centered thinking, you have to realize what's important to your stakeholders. This is not only your service recipients, but the communities in which they live, and what's important for them. You know, that how can they best benefit by your services? You have to think about what's working in your communities and what's not working, and, you know, build on the things that are working in your communities, and then see what you can do to creatively address what your communities see as not working about what you're doing. So we based this concept in Comal County, Texas, which is located on the Interstate 35 corridor between Austin and San Antonio. And you can see in the bottom right hand of the county map there, the city of New Braunfels that runs on the Highway 90 or Highway 35 corridor. That's their county seat, and that's where the majority of the population of the county was located. Significantly, Comal County is one of the 5 fastest growing counties in the United States in terms of percent population growth. You know, almost 60% of the population lives in New Braunfels, but you have a significant amount or number of folks with either diagnoses of serious mental illness or serious emotional disturbance who are living in the rural communities. We had one clinic located in New Braunfels, and that meant that it was a 20+ mile drive for many people who would want to access services. And we could see the impact that we had, because by the time we screened rural residents for crisis, as opposed to the more small urban folks for crisis, there was a 10% difference in the numbers that we recommended for inpatient services. And that was because they were not accessing or did not have the ability to access our services before they went into crisis. A study by the Meadows Mental Health Policy Institute demonstrated the majority of crisis calls for services appear to have come from our rural areas. Now, in understanding the environment, we had to understand what caused these issues. You know, one of the factors that we dealt with is the poverty level of persons with SMI or SED diagnosis in the rural community. And that impeded their ability to afford or obtain transportation to clinic services in New Braunfels. Those of you who provide rural care, you're very familiar with this. You know, transportation is a continuing issue. It was significant that over 2,000 persons with diagnosis of serious mental illness in this county were estimated to fall below the federal poverty level. If people did have employment, they could not afford to take the time needed to travel to and from the county seat at New Braunfels to attend intake or clinic appointments, either for themselves or if they had a child with a diagnosis or an SED issue, to take their child out of school and take their child to the clinic. That jeopardized their employment. We also were at maximum capacity in our New Braunfels facility, which I know many of you are familiar with, and this meant even lengthier wait times for intakes and psychiatric appointments. So all of this, we noted, was consistent with SAMHSA's 2017 Rural Mental Health Report that cited the issues of accessibility, availability, and acceptability as impediments to rural Americans who would seek or receive necessary and appropriate behavioral health services. For those of you in an urban environment, we're going to address this in our question and answers, hopefully after the presentation. The next thing we had to do is, once we understand what the needs were, we had to gain the trust of the stakeholders, because they were going to be critical to the success or failure of our operation. Fortunately for us, Comal County formed a mental health task force because they knew that they had serious issues, and they knew they particularly had issues in their rural part of their county. 29 organizations participated in the task force, and included first responders, police, sheriff, urban and rural emergency medical services, churches, nonprofits and civic organizations, local health providers, and local hospitals, as well as the 2 school districts. One school district served New Braunfels only. The other one, Comal Independent School District, served the remainder of the county. We attended with this, and it enabled us not only to identify core issues, but also key stakeholders in the rural environment who would enable us to establish footholds with the most trusted community partners, and have them assist us as advocates to enable us to gain the trust of the residents and the local community. From this, we developed as a task force a strategic plan. And based upon the data that we and other participants provided, including the Meadows Mental Health Policy Foundation, it emphasized the need to provide behavioral health services to the rural residents of the county. We proposed the Clinic Without Walls, and it was accepted by the entire force. And what really helped us was having this task group and having this strategic plan enabled us to apply for and receive a grant that we'll talk more about in a couple of slides from the Texas Health and Human Services Commission that allowed us to develop and implement the Clinic Without Walls system of care. It was critical as part of the strategic plan, getting to know the community, getting to know the needs, is determine who the influences are in the community. It doesn't matter if you're in a rural environment or an urban environment. You have key, as you know, you have key community resources out there that are established in your local community, in your urban or your rural environment. They're well known, they're well regarded, they're highly respected. These are going to be the essential partners who are going to influence the perceptions of the community and are going to really enable your success if you engage in this endeavor. Some of our partners included a Center for Emergency Health Services in 2 small communities where we actually located at their base site for the Center of Emergency Services. And they provided not only EMS, but we found out in working with them, they are a highly regarded provider in the United States. All branches of military services send medics to train with this center in in emergency health care. And in fact, this center actually holds patents in areas of emergency care services. So we had no idea about their influence until we met them as part of the strategic planning process and realized how influential they were. The McKenna Foundation was a highly regarded philanthropic organization that serves Comal County, and most of your major nonprofits and community organizations work closely with McKenna Foundation and receive funding from them. So McKenna, as an ally, was extremely influential because literally in some cases they could pick up the phone, call a key provider and tell them, you need to work with Hill Country on this project, and we would have a partnership virtually the next day. We partnered with the Canyon Lake Presbyterian Church. We actually based our second clinic base from the building that you see here. And we also partnered with what is known as the CRRC, which was the Community Resource and Recreation Center. They operated recreational services for seniors, but they also operated a food bank, a thrift clothing store, provided job training to folks who needed that service, and they also provided emergency rental and utility assistance. So they were an extremely valuable partner to us in establishing this project. And then we also partnered with the Comal Independent School District. This is all consistent with the Center for Disease Control and Prevention's principles of community engagement. You know, we have to work collaboratively and through groups of people affiliated by interest, geography, similar situations to affect the well-being of them and the folks they serve. So these partners we could not have been successful or done what we did without their involvement. So through our task force and our meetings with our participants, what we learned is that the Presbyterian Church hosted what they called the Happy Program. It was operated out of a branch of Methodist Healthcare Ministries, and it was a monthly clinic in their church, which provided clinic services, diagnostics, diabetes screening, wellness checks for indigent folks once a month. And that gave us the idea about contacting the church and seeing how we could work with them. When we did, we found that the building that I showed you in the previous slide actually housed a daycare center at one point. And they no longer could afford to operate it, and they closed it. So they had a tremendous amount of empty space in that building, which enabled us to work with them to base one of our clinic operations there. The Center for Emergency Services operated the WOW program, Wellness on Wheels, which was a beautiful trailer fully equipped to provide mobile health clinic in the Spring Branch Bulverde communities. And their data that they provided, which also helped us in our application to the state, demonstrated that in 2016, 44% of the individuals that they saw and served in that mobile clinic had an underlying mental health condition. I told you about the CRRC and also about the Comal Independent School District. So not only did we reach out to the Presbyterian Church, we partnered with the Center for Emergency Services to utilize vacant office space with them, and also to embed a certified peer specialist with their WOW team whenever they traveled into the community. We reached an agreement with the CRRC, the Community Resource and Recreation Center, to transport people we serve to their site for assistance with food, clothing, rent utilities, job searches, and in turn, we took referrals directly from them. About 2 years after with this program, they moved into the new site, which you saw on the slide, and they started operating a health clinic there. And at that point, we embedded with them for integrated services. And then we also hired a certified family partner to work with the parents of Comal Independent School District youth that we served. And we also hired a children's care coordinator to work directly with the youth. And the school system now at 3 schools provides us permanent office space so that we can travel there, operate, and see families and children. So then comes the question to everybody. Okay, it's a great idea, you know, sounds wonderful. How do you pay for it? In this respect, the timing was very fortuitous for us, because at the same time that we were working on the strategic plan, the Texas legislature passed House Bill 13, and it funded the Texas Health and Human Services Commission to establish a Manchi grant program to support mental health programs for persons experiencing a serious mental illness or serious emotional disturbance. We had to meet the behavioral health needs that were identified in the statewide strategic plan for behavioral health. And out of the 10 needs identified in their strategic plan, we were able to meet 6 of those. We could not duplicate existing services, and we had to reflect community input and collaboration, which we did through that strategic planning process and through letters of endorsement that we received from all of the partners who participated. The crucial proviso in this, and this is the one that everyone who applied for these grants had to struggle with. If the county in which the program was going to be located was above 250,000 in population, the service provider organization had to provide a 100% match for every dollar HHSC provided, either in in-kind service or actual cash. In our case, our county was under 250,000, and we had to provide 50% match for every dollar received from HHSC in cash or in kind. So what that meant was, to operate this clinic, we began with an annual budget of $840,000. And of that, when we were approved for the grant by HHSC, HHSC would provide $560,000 of the grant, and we had to provide 50% of that amount, which was $280,000, and that equaled the $840 operating cost for the operation. So in 2018, we initiated evidence-based operations. We operated out of the 2 clinic bases located in the Presbyterian Church in Canyon Lake and the Center for Emergency Services in the Spring Branch Bulverde communities. We offered expanded hours, initially 3 days per week at the church, 1 day a week at the Center for Emergency Services, and then we worked 2 half days on Saturdays. This was to allow for folks who could not take off from work to either get themselves or their family member or child to work, out of school, to attend our services at non-traditional hours. And I know you're all familiar with that, and we found that to be highly successful. As part of the grant, we provided free transportation services to and from appointments, and as well as to other community resources, notably the CRRC. As I mentioned before, we provided telepsychiatry services, and we eventually arranged the schedule so that every staff would provide services in the community 1 full day per week, and that we had a staff member in the community working at least every day during the week. We provided family partner services to families of youth with serious emotional disturbance, children's care coordinations at home, at our base, or in the school. We had a licensed therapist. We embedded with the Wellness on Wheels to provide physical and mental health screenings. We also provided COPS-D, co-occurring mental health and substance abuse services. And we interacted with the communities to provide information and education regarding our services and to reduce stigma and to secure alternative locations. To give you an example of that, our clinic director was having coffee at a local coffee shop nearby the Center for Emergency Services, and the owner of the shop saw his name badge, began talking with him, and offered the fact that they opened for breakfast and lunch and closed at 3 p.m. every day. And he offered us full use of his cafe coffee shop, which was a popular community hub, any afternoon we wanted after they closed, so that we could do groups, we could have individual meetings. Our staff joined civic organizations, attended stakeholder meetings, church services, and soon we had others in the community reaching out to us to offer their facilities for our utilization. Of course, nothing occurs without challenges. And we definitely had some challenges when we initiated this project. One of our major ones, and I have to be honest about this, is the financial. As I said, HHSC would provide $560,000, but we had to come up with 50% of that, or $280,000 in cash or in-kind match. And as we all know, our communities are cash strapped, and the cash resources in both rural and urban environments are scarce. So we relied on in-kind to achieve our match. We were able to get free office space from the church, from the emergency services. We could add the WOW, this is a photograph of it at the top right, vehicle equipment, mileage, and personnel add their value. The McKenna Foundation donated the vehicle that you see at the bottom right, the Ford Flex, which was wonderful because it does not, we could carry several, I say carry, we could transport and provide transportation for several folks. And it's not your traditional marked van or marked vehicle. So it looks just like any other vehicle in the community and helped us to reduce stigma. We also could utilize patient's assistant program, a medication value as a match. But the reality was we still had to fund the program, and personnel costs were our largest expense. So while we were able to provide the in-kind match to meet the terms of the grant, we still had to pay out of pocket to cover those expenses between $560,000, $840,000. And to do that, we utilize, Texas has an 1115 Medicaid waiver program, and we were allowed to use revenues from that program to fund the difference for anything that we needed to do to make up any difference in funding. We also had to overcome stigma. It was interesting that one of the most significant barriers was actually the congregation of the church. The governing body, the elders and deacons of the church, many of them were former human service providers, and they unanimously endorsed the project. What we found was that most of the members of the congregation were older adults, and even though conceptually they liked the idea, they had a lot of misconceptions about folks with SMI or SED diagnosis, and were very fearful about, what would this mean for their church and for their congregation. We addressed that by we actually attended church services. We met with the staff during covered dish luncheons to provide information, answer questions, address their fears and concerns. And we encouraged them to hit us with every possible challenge and fear that they had. And it really made for quite a vibrant give and take. I mean, one of the things that we emphasized is, we didn't sugarcoat anything. We were upfront, but we also had data. We were able to show that statistically, persons with mental illness diagnoses are far more the victim of crime than the perpetrators of crime. But with, things such as mass shooting, media coverage, there was a lot of stigmatized fear there, and we confronted that head on through the question and answers. We were also very fortunate in that when we first were initiating this, the church had an interim pastor, and a new younger pastor was looking for a congregation, looked at the church, read about our program, and was inspired to join the congregation because he literally saw this as being a true mission and a true service of what a congregation was meant to do. So he came in at that time and helped shepherd the congregation and church. And what we're very fortunate with is the church now fully embraces the clinic. In fact, at one point we were talking about relocating and moving completely to the new headquarters of the Community Resource and Recreation Center. And the church asked us to stay because they valued the project so much. He found that his greatest challenge now is ensuring boundaries of members because they want to assist people with genuine compassion. but they have to be reminded periodically of HIPAA concerns and protecting the privacy and dignity of folks. So instead, what they've done is they provide a mini food bank at the clinic, which was an Eagle Scout project. And they wrote and obtained a grant to provide community education and business support. And what they do now is they go to businesses in the community and they have a sticker made and they speak to the business about what we do for their community. And if the business agrees to come on board, and this is a new project, so I don't have the data on how many businesses have joined, but if the business chooses to be involved, then what they do is agree to have one of their staff members trained in mental health first aid. In turn, they receive a sticker on their door, that identifies them as a safe locale or on their window. And there's a directory, a community directory, and their business is prominently named in that community directory. So it's a win-win for both organizations, but this was spearheaded completely by the congregation. So to ensure a successful implementation, what we would tell you is you have to collaborate effectively with your partners. You have to address community concerns. You have to be honest. You have to, when you don't know something, you have to say you don't know. You have to let them know what you can do and can't do. We all have funding constraints, and we're upfront about what our contracts with the state and other providers allow us to do and not do. We have to tell them what the statutes allow us to do and not do. And that's key when we're interacting with elected officials and law enforcement. We've had many a hostile meeting at onset of services with local communities. And we find that when we tell them, here's our contractual requirements, we get it. We know you don't like it, but here's our boundaries. They're either legal boundaries or contractual boundaries. But we never say we can't do something. What we instead say is, given those boundaries, how can we work with you to address these needs and be successful? And we found that works quite well. We were very fortunate that we hired an extremely dynamic, and I call him young, clinic director, early 30s. This was his first leadership position, but he completely embraced the philosophy of person-centered services and person-centered thinking. And the community has virtually adopted him. He is recognized in all of the communities where we operate. He's extremely active, and not only does he interact well with the community and is very good at explaining things that we can do and can't do and things that we're willing to do, he divides his time to also engage in problem solving and to continue to educate our own staff in person-centered thinking principles, and takes great care to oversee and attend to their professional growth and their personal and emotional well-being. We also implemented person-centered atmospheres in our programs to do everything we could to eliminate barriers and make people feel welcome the minute they walk in our door. And among these other things, to be successful, we have continually attempting to expand our collaborative opportunities. Some of our outcomes is we have an initial outcome for the grant of 271 unduplicated persons served per state fiscal year. That first year we served 448. We had a screening target for a crisis who required hospitalization of under 53. In our first 9 months, our actual data showed 49.5%, and in the last quarter of that year, 41.56% required hospitalization when we screened them in crisis. We expanded our operations. We joined with the CRC's medical unit. We now count the ISD school offices as part of our in-kind matches. And we've also had multiple community businesses, churches, libraries, and other organizations offering facilities so that we can meet with folks there. And this is just a quote from somebody that we worked with at Comal ISD. And this outcome on the right is going to be extremely poignant when we talk about, in this next slide, our lessons learned. Michelle Solomon, whose photograph on the right, is the CEO for the Center for Emergency Services. And when we asked her, what would you recommend? This is one of the things that she told us is, do not wait for things to be perfect. We initiated with, how is it going to work? Now what we've seen, it works beautifully. The question is, how can we improve it? The Reverend Chad Lawson's photograph is on the bottom right of your screen. And this is how he served, is to minimize stigma, educate, join with us in educating the community. He worked very actively with his fellow ministers, and other churches now people to us. And what we found was when we attended community meetings prior to starting up the project, we learned that one of our most critical allies is the church secretary, because the church secretary is the one who is the front door for folks in need who come to the church for help. And when we first attended a community meeting and there were some church secretaries there, literally one of them broke down in tears because she said, we have been begging for this service to occur. So it's working and identifying who are going to be your referral sources. And as Michelle said at the top right, we never ripped the Band-Aid off mental health prior, because once we did, what would we do? Once we identified an issue or a need, there was not a service to address it. Now there's an active referral process in the communities. And then you can see the ways on the bottom right of how the church provide support to us in our efforts in Canyon Lake. Some of the do's from our clinic director is to meet all the partners to understand what their rules are. And as I said, they have to understand what our rules are. And from all of the folks that we spoke with about this project, it's critical to be flexible. We have to address the needs of the community. We have to address availability of services. How can we provide them? How can we expand them? Where are we successful? Where are we not? Again, the working, not working. You should have 3 to 5 collaborative leaders, your influences, who can meet as needed to discuss the project, and with a critical eye as to how can it be improved upon. You don't want to wait for the perfect alignment, but you use the resource to the maximum. Nurture real relationships and find out what your network is and tap into it. Above all, communicate, communicate, communicate. For don'ts, don't be afraid to fail. You've got to take informed risks to be successful. Don't refuse to commit for the long haul. If you're going to do it, you have to be committed to do it, and recognize you're going to have good days, you're going to have bad days. Never assume that you know that, or that others know what you're thinking or doing. Again, we come back to communicate. You have to explain to them what your thought processes are, what your rules are, what your statutes are, what your contractual requirements are, and whether you think something is working or not working. Don't assume that you know what they're doing and what they're thinking. And do not let your vision get in the way of reality. If the end point changes, be okay with it. As Michelle said, there's 1,000 ways to accomplish a goal, and that each way may be different. So with that, I just want to end with a quote from the World Health Organization. And this is what we think the Clinic Without Walls does, is we're doing everything we can to address their physical, mental, and social well-being. And with that, I would encourage any questions Jason, I don't know if you have any or if the audience has any, but I very much appreciate your time and thank you for the opportunity to share this program with you.
Thank you for that presentation, Ross. It's a terrific example of meeting people where they are in so many ways. I do have a few questions. So when you spoke about, that it works in an urban environment as well as a rural environment, I'm wondering for people who might be viewing this saying, okay, this worked well and good for a rural environment. How do I do it in an urban environment? How do I transfer it over to that type of environment?
That's a good question because, Jason, as you and I have discussed in the past, that if I were a CEO or an executive listening to and viewing this presentation, I would have somewhat of a cynical eye and cynical mindset is that, and just say, okay, explain to me how this works in my environment. Essentially, what we presented were, concepts and action steps. And they just happen to be in a rural environment. And they work very well in that rural environment. But the concepts and principles don't change if your environment changes. They remain the same if you're in an urban environment. One of the things that, in looking at data and research regarding urban environments is that even if you have a clinic in an urban setting, people still struggle to get there, particularly if it's that old walls around you fort concept. And so the concept of, even if you're in an urban environment, finding where the people are, finding where the providers are, finding out where the trusted locations are that people come to for services. In many communities, those are your churches, those are your social centers, your boys clubs, your girls clubs, your Ys, your food banks, things that are your organizations, your schools that are the trusted locations for your urban or your small urban environment. There are organizations that you work with that are influencers. So the important thing is to study your environment, be in your environment, be it rural or urban. Get to know your influencers. Get to know from them what the needs are. Hold the community meetings with them. A lot of times what we find in our services is that people are very, when we first initiate interactions, people are unhappy with us. They think that I'm sure every executive has heard that, you're not meeting the needs of the communities. Law enforcement is having to handle your job for you. You're letting the ER serve folks that you should be serving. And it's important to realize that those issues are out there and allow people to vent those to you while at the same time working with them to say, we get it. Here's our limitations. We're not making excuses. That's the important thing, is for them not to think that you're making excuses, but instead to say, here's our reality. Here's our funding. Here's our statutes. You can look at the data nationwide, and ERs are the #1 hospital research for folks with serious mental illness diagnosis or serious emergency disturbances. We get that. How can we work with your healthcare providers? How can we work with your law enforcement? How can we work with your churches? So the principles that are outlined in here work either way. We just did it in a rural environment. You can put folks in the community. Use your community clinic as your base of operations. People will always want to come there. That's fine. People enjoy getting out. But you also have to say, how can we help people get here? How can we help people with transportation? How can we meet people where they are, either in their homes or in their trusted locations? Because they're able to get to church if they need to or want to. They're able to get to school. They're able to get to other locations. Can we be in those locations so when they come there, they're there with us? I hope that helps with that question, Jason.
It shows that it's adaptable, and also in an urban environment, like public transportation is often a barrier too. Like not everyone has the same type of access.
Exactly. How can we assist with public transportation?
So the next question we had is, since technology is playing such a huge role right now in being creative and innovating, what type of technological solutions did you use in the field to support the staff in the field as well as enable consumer outcomes?
Well, realizing that we were in a rural environment, one of the first things that we did was we equipped all staff with radios, just in case their phones weren't working, so that we had radio communication with everyone wherever they were. If somebody was going into the community, we would know when they were going there and when we expected them back. As we said earlier, as part of the grant, we obtained laptops. So for people who physically were unable to come to our clinic, or for whatever reason were unwilling to come to the clinic, we really utilized our certified peer specialists to build relationships with them to gain their trust. And then the peer specialist could take the laptop to their home with secure communications, so they could engage in telehealth with the provider, either with the therapist, with the psychiatric nurse practitioner, or with the psychiatrist. We also worked with our local internet providers to see how we could, as part of our in-kind match, boost our capacity with our internet to strengthen, because in a rural, that's always a struggle with internet. And we're very fortunate in Comal County. There is a telecommunications company there that is extremely community minded, that work very closely with us. And then we did establish one of the things, because Hill Country served 19 counties, over 23,000 square miles, larger than combined area of 5 states in the United States. We had already relied very heavily upon telecommunication and telepsychiatry. And so we were very experienced in that. We implemented that. And then with COVID, the rules relaxed and the legal requirements relaxed, to where psychiatrists would not, could provide their services via either telephone or telemedicine. A lot of the barriers got taken down. So COVID, in that respect, actually worked to our advantage, to where people could do intakes via telephone, and the psychiatrist could do psychiatric consultation, that even if the person did not have a computer, they could do it by phone. So we were able to just utilize our technology a little bit differently. But from the very beginning, we wanted to take the technology into the community, so where people could have access and get to us either via laptop, telephone, if they could not get to us in person.
Great. And the next one I want to talk about is, how did you measure success and outcomes and share information and data effectively? This is particularly important as people who might be trying to implement this in their own areas are functioning more and more in a value-based world.
Full transparency is the data sharing has been one of our biggest obstacles. We had an outdated system for data, and the center, I retired in August, and our center just now went live with NetSmart just 2 weeks ago. So that was something to be completely upfront. The data sharing we struggled with. It was not easy. It was not easy sharing the data with the state, linking our system with the state systems. Fortunately, we, over the years, we had those linkages already worked out. And so we were able to work with them. Now we have the ability, and this is one, because what you mentioned, Jason, was one of the questions that the CEO of the Center for Emergency Services brought up when I met with them over the summer about successes and challenges. And she was worried about the data sharing. And now we have the ability to share data with them, HIPAA protected data. And they can share data with us, and we can share data with them, which is also integral to the CCBHC process. And Hill Country is completing the certification process to become CCBHC certified. And so we had to do that for CCBHC. which is why we changed our data systems, and now we are able to link. As far as the outcomes, some of the outcomes were established through the grant, and the state established them for us. For example, we had to serve a certain number of unduplicated individuals annually. We had to serve a number of unduplicated individuals monthly. We had to have a baseline of service encounters by discipline that we had to demonstrate. That included psychosocial rehab and skills, med management, peer support, counseling, routine case management, COPS-D, crisis intervention, and intake and psychiatric evaluation. We also had some measurements that were related from the 1115 waiver. So we had to demonstrate outcomes related to improving individual functioning and autonomy. And we measured that utilizing the ANSA for adults, CANS for kids, and look at their risk behaviors, their behavioral health needs, life domain functioning, strengths, adjustment to trauma, and substance abuse. And we had a percent improvement that we had to demonstrate for a person served. Through those same, we had to show improvement in quality of life, prevention of adverse events, and return on investment. So those were some of the outcomes that we had to do. And now we're rolling over to the CCBHC based outcomes.
Great. So I think Stacy's going to come back on now to wrap things up. Thanks for these descriptive answers. It really put a clearer picture on things and gave us more details.
I very much appreciate the questions. Thank you.
Thank you both. It was a great presentation. I think we all learned a lot. And I want to thank all of you who have attended and remind everyone that the slides and recording will be available tomorrow on the Open Minds website. The full series of these sessions are also available on demand as part of our extensive Open Minds library. And we'd like you to place a mark on your calendar for Thursday, January 6th, when the 2022 series begins at 1 p.m. Eastern Time for our Circle Elite Executive Roundtable, Going Hybrid, Powering Your Future Care Model with the Right Technology, featuring Carolyn Spence, CIO of Alexander Youth Network, and Open Minds Senior Associate Dr. Carol Clayton. For a full list of upcoming roundtables or to register for the January 6th roundtable, please visit the Executive Web Roundtables under the Events tab at openminds.com. Thank you both, and thank you all for joining us. Have a fabulous day.
Thank you.
Thank you.